Hi, my name is Channa Amarasekera. I'm an assistant professor at Northwestern Medicine, and I'm the director of the Gay and Bisexual Men's Urology program. Broadly speaking, there are three arms to the mission of the Gay and Bisexual Men's Urology program. So there's the clinical arm, where we aim to create a safe space for gay and bisexual men to disclose their health conditions. Then the second part of it is educational, where we try to create educational materials that are specific to this community to help educate both providers and patients. And the third part of it is research to uncover areas of urology that are specific or different for this population compared to the general population, and then use that to inform what needs to change within the clinical practice of urology. We developed this program is to help accelerate acceptance and a safe space for these patients. The program started its research on prostate cancer in gay and bisexual men. That's the starting point because there was very little information known about it. And prostate cancer can be experienced very differently by gay and bisexual men by virtue of differences in sexual experiences, differences in social structure, and other differences in how healthcare is generally experienced. Since then, we've sort of branched out into looking at how BPH, erectile dysfunction, Peyronie's disease, how these other urologic conditions can affect gay and bisexual men differently. In terms of systematic interventions, I think it's important to think about both the healthcare needs and the clinical side of things, but also the social aspect of clinical care. So from a urologic standpoint, if you think about prostate cancer, because of differences in sexual identities or sexual, essentially, behaviors, gay men and bisexual men, or men who have sex with men in general, might experience these symptoms differently. So, for example, there's pretty good data that show that gay and bisexual men, or MSM, have differences in how they value ejaculate or preservation of ejaculate with treatment. Compared to their heterosexual peers, it's much more important for MSM. So counseling these patients about the fact that this might happen, they might have a change in ejaculate after treatment, can help set up expectations, but it can also help guide patients away from particular procedures that might have a higher risk of this happening. Other examples are if patients engage in receptive anal intercourse, you may not want to do radiation, which might have subsequent downstream effects like rectal fibrosis, which may make it painful or impossible for some men to have receptive anal intercourse. In terms of erectile function, if you think about anal intercourse, there's got to be a firmer erection for the inserted partner to be able to perform. And you might be careful about what you recommend, because if there's something that might be more detrimental to erectile function, those patients may not want to proceed with that particular treatment and may want something very different. So it's a matter of balancing oncologic outcomes with what patients want afterwards, because yes, treating the cancer is very important, but there's a lot of life left after cancer treatment, and they've got to be mindful about survivorship too. It's also important to talk about the social aspects. Medicine historically has assumed that couples are dyads, and often heterosexual dyads, where there's a man and a woman. And even when it thinks about non-heterosexual couples, typically it's thought of as a monogamous close relationship. And that may not be the social structure that a lot of our patients who don't identify as heterosexual, or even those who identify as heterosexual, may engage in very different structures. I think the lack of expectations on gay and non-gender conforming couples means that they can explore other options other than what's traditional. So when counseling these patients, it's important to know who their social network is and invite those people within the social network to make decisions with the patient and be sure you're not excluding important parts of their social support system.